So without further ado, I'd like to invite our three panelists for this morning up to the stage. Dr. Jessica Altman from Northwestern, Dr. Joe Alvarez from City of Hope, and Dr. Peter Greenberg from Stanford. And we look forward to an exciting case discussion.
This morning, what I'll be talking about are the myeloproliferative neoplasms and some of the issues that we find often bedevil us. Diagnostic issues, prognostic, as well as therapeutic approaches. And we'll start with a case. You can see here that we have phenotypic mimicry that occurs in some of these patients. Some of them are common, some of them are uncommon. We need to know something about survival as well as thrombotic risk in these patients. And then we want to know something about what about the JAK2 inhibitors, which ones should be used and when. And now molecular changes are occurring. How do we use these? Case 1. It's a 68-year-old man who presents with headaches, visual disturbances, a past history that includes an unprovoked lower extremity DVT, treated without recurrence, and a bleeding duodenal ulcer. He's no longer symptomatic from these, and he lacks pulmonary or constitutional symptoms. Physical exam shows mild hypertension, a negative fundoscopic exam, palpable spleen, and then no nodes or edema. CBC. It's got a white count of 16,000, hemoglobin 16.5, MCV 79, hematocrit 49, platelets 600,000. Differential 60 neutrophils, 35 lymphs, and 5 monocytes. Peripheral smear shows mixed micro and normocytic red cells, 2% retics, large and clumped platelets, normal white cell morphology. Questions? So you have at your hand there something that you can push to answer some questions. What laboratory studies would you next request? Serum creatinine, serum erythropoietin, red cell mass if available, JAK2 mutation analysis, or numbers 2, 3, and 4. Okay. Do we see the responses? Thank you. Good. Okay. Yes. Okay. So nearly everyone essentially is discussing the issue of looking at serum erythropoietin, red cell mass if available, and a JAK2 mutation analysis. Certainly, some people feel just a JAK2 mutation analysis would be important, and I suppose that's understandable, but certainly one would want to know that a serum EPO level is relatively low. In your differential, which would be your primary diagnostic consideration? Central thrombocythemia, reactive thrombocytosis, polycythemia vera, secondary polycythemia, or myelofibrosis? Okay, so it looks like most people certainly got polycythemia vera, which I think is quite reasonable. There are some issues that come up as to whether or not this is essential thrombocythemia or not, but clearly it looks like there's very little evidence for thrombocytosis being reactive. So what about this? The myeloproliferative neoplasms we know are multiple. They're classical ones, PV, ET, myelofibrosis, and CML. Less common ones that are becoming more notable these days, chronic neutrophilic leukemia, mastocytosis, chronic eosinophilic leukemia, and undifferentiated MPNs. And then we have a mixture of MDS MPNs that include CMML or JMML, atypical CML, which is a BCR-ABL negative CML, and overlap syndromes with MDS MPN, and RARS-T, an entity that previously had been solely in the MDS camp, but now looks like it's an overlap syndrome. That certainly is an important one to know with myeloproliferative components. So what about the diagnostic criteria for polycythemia vera? By WHO criteria, we know that there are several major and minor criteria. The major criteria include hemoglobin level, male and female, somewhat different between the two, JAK2 mutations being major, and the minor criteria being marrow panmyelosis, decreased serum EPO, and endogenous erythroid colony formation. So if you have two from column A, two major, then you have a diagnosis. If you have individuals that have only one, that is the top one, that is hemoglobin levels, then one needs at least two from column B, the minor criteria, to make a diagnosis. And you'll notice that in our patient, there is a bit of a controversy as what we should do with this patient who has a hemoglobin of 16.5, not 18.5. And so that's why some of the other testing was necessary. And so essential thrombocythemia, what are the distinctions between this or secondary thrombocytoses? Platelet elevation should be above 450,000, and large megakaryocytes, needs a JAK2 mutation, and one needs to rule out reactive thrombocytosis, iron deficiency as well, and consider masked polycythemia vera. So it's masked P vera that often one needs to deal with when you're questioning whether this is PV or ET. And so here it looks like if one has a hemoglobin of 16.5 or more in a male, or a woman 16, if you have a JAK2 mutation and the patient is iron deficient, in other words, capable of mounting this, then you have enough to call polycythemia vera. And he had a retic count of 2%, as you noticed, which is pretty high for someone with this level. And so someone with this who has a low serum EPO, clearly one has an endogenous production of erythroid cells. One also needs the absence of peripheral blood or marrow features of myelofibrosis, absence of dyserythropoietic features of RARS-T, and BCR-ABL mutation negative. So that's what we have for this patient. And what is the distinction between essential thrombocythemia and prefibrotic myelofibrosis? So that's something that's becoming better understood, and I think Jessica will be talking about this a little bit more. This is a patient with prefibrotic myelofibrosis who has anemia, thrombocytosis and splenomegaly, megakaryocytic atypia, hypercellularity with granulocytic predominance. So this is something that more goes for prefibrotic myelofibrosis than ET, something one needs to be aware of. And in addition, one can also get the leukoerythroblastic peripheral blood smear, which can be helpful in that regard. Question. So here's our patient who most of you thought had polycythemia vera. What is the treatment that we would recognize for him or recommend? Aspirin, anagrelide, hydroxyurea, ruxolitinib, phlebotomy, or numbers 1, 3, and 5. That is aspirin, hydroxyurea, and phlebotomy. What do you think? Okay. These questions are too easy, I think. What can you say? Good. Yes, of course. So I think that the patient who is over 60, who's had a prior thrombotic event, clearly one needs to intervene in some way. Aspirin, certainly reasonable, hydroxyurea to drop his counts, and phlebotomy to get a hematocrit below 45.
Can I ask a question?
Yes.
Which of the, what would you start with? Would you start with phlebotomy or would you start with hydrea in this patient?
Well, there's no major difference. There's nothing acute going on here, so you could do either. I think that I would certainly start with aspirin and probably hydroxyurea. Get the platelet count down first and then start phlebotomizing the patient. Because post-phlebotomy, certainly you can get a thrombocytosis, and that would be a problem.
Do you think that any component of the elevated platelet count is related to potential anemia? I mean, iron deficiency anemia in mass?
It could be. It's hard to know in patients with iron deficiency how much of that is reactive as opposed to endogenously produced, but certainly there is a component of it.
Okay.
Right. So now, how do we evaluate patients with MPNs with regard to their prognosis? There are now prognostic scoring systems for ET, myelofibrosis, and polycythemia vera. Jessica will talk more about myelofibrosis, but as you can see here, there are a variety of parameters that are important here. In polycythemia vera, white count elevation, age, and prior thrombotic event is something that puts someone into a poorer prognostic category. Patients with ET, the same thing. So these are things that it's been validated in certain studies that have been documented here. Myelofibrosis, you can see a much longer list of issues that are going on, and certainly anemia, and particularly transfusion-dependent anemia, is an important component. Karyotype is also important, as well as thrombocytopenia, as opposed to thrombocytosis, playing a major role. Determinants of thrombotic risk. So these are issues that are important for us to know how active we need to be in therapy. Age, thrombotic history, leukocytosis, JAK2 mutation burden, but also platelet leukocyte and endothelial activation, protein C resistance, inflammation, or circulating microparticles. Questions? What's the initial aim of your therapy? Control the white count, decrease hematocrit to less than 45, platelets less than 600,000, treat iron deficiency, or decrease splenomegaly. True to our calling, another easy question. I'm sorry. Okay. So that's certainly the idea. Data have shown that one should get the hematocrit down below 45 with regard to overall outcomes and platelet counts to decrease thrombotic events. Although initial good control of his platelet level and hematocrit occurred, he is now resistant to hydroxyurea. What is your next treatment approach? Phlebotomy, anagrelide, ruxolitinib, or PEG interferon? Good. So there's debate here, so that's fine. So phlebotomy we probably wouldn't consider to be appropriate because the patient is resistant to control, and therefore generally it means that his hematocrit is not well controlled. So that alone probably is unlikely. Anagrelide is a possibility. Certainly people could consider this, although data have shown that as for arterial events, hydroxyurea is somewhat better, so we have a bit of a problem here. And then PEG interferon, although can be useful in people that have not tolerated other things, is not often as useful as the use now of ruxolitinib. So the data here would say that if one has a patient that is resistant to the standard therapy for P-Vera, there can be complete responses in 59% of patients, phlebotomy independence in 60%, decreased constitutional symptoms, as well as thrombotic events. So there are now data to use this, and that's really the only indication for using it in patients with P-Vera, those that are resistant to standard therapy. Now the question is, what about molecular features? Are there molecular features that contribute to the disease and its presentation, its phenotype? Calreticulin mutation, JAK2 mutation, a MIPL mutation, a BRAF mutation, and numbers 1, 2, and 3. So this is for all MPNs, not just P-Vera. Good. Okay. So I'm not going to be able to teach you very much today. All right. So clinical outcomes in patients with myeloproliferative neoplasms. So here we have the outcomes in patients with PVERA, ET, and myelofibrosis. As you can see, the survival of patients with PVERA and ET is variable depending on the risk features that were present when I described what the risk scoring systems were. So that, for example, in polycythemia vera, survival can be anywhere from median of 11 to 27 years. Okay, this is an order of magnitude different than what we're talking about in MDS, for example, but at least you can see that there are differences in PVERA patients. And there's about a 10% potential for evolution to acute leukemia within 20 years. So it's generally indolent. ET, pretty much the same thing, although there's a lesser incidence of evolution, maybe 5% over a 20-year period. On the other hand, MF is quite different, and Jessica will talk about this in more detail, but you can see survival from anywhere from a little over a year to 15 years, with a variability of 5 to 30% of patients developing acute leukemia. And in the MF patients, it appears that the molecular features make a big difference as to patients' outcome. Those patients with calreticulin mutations do better than those with either a JAK2 or a MPL mutation. But those that have none of the three mutations do extremely worse. So that those are individuals that have a survival, a median of 3 years, and over 30% of the patients can develop acute leukemia. So it appears that if one wants to have some input on prognosis in these individuals, molecular features can make a big difference. And this just shows you the implications of these mutations in ET compared to polycythemia vera. Those individuals with JAK2 mutations may have more thrombotic events than individuals that have the calreticulin mutation. So calreticulin mutation appears to be somewhat better with regard to outcome in these individuals, both for leukemic transformation, myelofibrotic transformation, as well as for thrombotic events. What about the sequence? In individuals with these problems, they can have a different set of sequences. Some people will have TET2 mutations, and about 10% of patients' TET2 mutations are present in addition to JAK2. So just because a patient has a JAK2 mutation doesn't mean he doesn't have many others, and one of them is TET2. And one of the issues that occurs is, why do these MPNs develop into ET, PV, MF phenotypes? Data have shown that if one has JAK2 first, there's a much higher incidence of patients having PV-ET compared to myelofibrosis, and also PV more than ET. So that gives you some idea of some of the impact of these mutations on patients, on the patient's phenotype. It also suggests that these patients may be more responsive to ruxolitinib. I think there was... Yes, here's one more slide that shows you that when you look at these mutations, PV, ET, and myelofibrosis have all three of these potential mutations. An LNK mutation is present sometimes in PVERA, but TET2 is present, as I've just mentioned, in all of them as well. And the sequence with which they occur appears to be important as to what the phenotype will be. You can see that in CML, we have single lesion that makes a difference, BCR-ABL. Atypical CML, we now know that the GCSF receptor is mutated in a high proportion of these patients, as well as CETBP1. There are specific mutations that occur in myeloid neoplasms with eosinophilia. PDGF receptor alpha and beta are often abnormal. Systemic mastocytosis, the KIT mutation is present there. And refractory anemia with ring sideroblasts often has the SF3B1 mutation, similar to what happens with just refractory anemia with or without thrombocytosis. So phenotypically, things can be markedly different. And now the question is, what about targets? Will these ultimately be useful targets beyond what we're already doing with the JAK2 mutations inhibitors? And so lastly, Where's the direction? Where are things going with this disease? Comparative trials with therapeutic agents, new drugs. Imetelstat is an inhibitor of telomerase that's being used and just being recently reported. Combinations of agents, including interferon, can be important, along with the JAK2 inhibitors. Can we target the calreticulin mutation? What's the impact of that? And how do we better control symptom management? So with that, I will conclude and ask for any questions with regard to... Okay.
To keep because we have two other cases to discuss, let's leave questions to the end.
Good.
And
let Jessica talk now. Jessica Altman.
So, Jessica, please.
Yes. Good morning, everyone. In the interest of time, I will really cut straight to the chase. I think that a very nice overview of the myeloproliferative neoplasms was already provided. So I want to let you know about a patient that I have taken care of with a myeloproliferative neoplasm. As occurs frequently in MPNs, we meet these patients at various time points in their career, and sometimes the story has already begun, and we are catching it midway. So I'll let you know about a patient that I met later in her course, but her background is she was a 71-year-old woman who in March of 2008 developed persistent leukocytosis, frequent infections, and weight loss, about 5% of her body weight. She was noted to have splenomegaly on exam 4 centimeters below the costal margin, and her marrow revealed primary myelofibrosis with a mutation, JAK2 mutation present. On referral to Northwestern, she had an elevated white blood cell count, a hemoglobin of 13, and a preserved platelet count at 341. What factors are used to determine the prognosis as I was having a conversation with her? Number 1, age, leukocyte count, hemoglobin, circulating blast percentage, the presence of constitutional symptoms, or all of the above. As you all are determining your answers and we'll show the responses, I'd like to turn to my esteemed colleagues and ask them which of those they are thinking about when they're assessing a patient with concern for myeloproliferative neoplasm, specifically myelofibrosis. Dr. Greenberg?
All of the above.
Excellent. Is there any that you feel have more clinical weight than the others?
None particularly, but why don't you tell us, Jessica?
I'll look at the circulating blast percentage perhaps fairly closely.
Right. I think as concern for disease transformation, I worry most on biologically about the blast percentage, but certainly when you're interacting with a patient and assessing their quality of life, their constitutional symptoms have a major role. Certainly age helps us assess as one of the factors along with their comorbidities of whether or not we'll be thinking about stem cell transplant, which is the only curative modality for patients with myelofibrosis. Next slide. Okay. So a bit about prognosis, and many of you are familiar with the dynamic IPSS. The factors that are utilized to assess prognosis include age, leukocyte count, hemoglobin, the presence of circulating blasts, and constitutional symptoms. There is a modification of the dynamic IPSS called the DIPSS Plus, which adds the presence of karyotypic abnormalities, red cell transfusion need, and thrombocytopenia, so a little bit more of additional clinical and biologic information. Dr. Greenberg, do you have any thoughts about how this informs your decision making and if there are limitations in the DIPSS in your experience?
Well, certainly these are very valuable and show you whether or not you have higher or lower risk patients, whether or not your aim is mainly to have hematologic improvement, constitutional symptom control, or one needs to have active intervention.
Excellent. Okay. Maybe I can go to my next slide. There we go. So this woman at initial presentation was followed expectantly. This is in the era when we had therapies that were only utilized for symptom control. So if you recall correctly, she had a little bit of splenomegaly, no early satiety, and a high white blood cell count, but a normal hemoglobin and platelets that were not affecting her life. The story changed. About a year and a half later, she presented to our institution for follow-up with progressive symptomatic splenomegaly and now pruritus. And her spleen had gone from about 4 centimeters below the costal margin to 21 centimeters below the costal margin. And I'd like to ask my colleagues, what would you offer her now? Dr. Alvarez.
I mean, it depends what the goals of care are for this person. I would look very carefully at what comorbidities are present. She's now 73 years old. Her candidacy for transplant becomes maybe more suspect. So depending upon what her principal symptoms are, the scope that you can choose from range from things like hydroxyurea to relieve her symptoms toward a strategy that moves toward transplant if she was a high performance status patient with few or no comorbidities.
Yeah, and the other thing is for her splenomegaly, which is probably symptomatic, think about ruxolitinib.
Excellent. So fortunately, we were a center that had the phase 3 randomized trial open. Ruxolitinib had not been approved yet at this time, and so she enrolled, signed consent and enrolled in this clinical protocol. It was a blinded study, though now many of us utilizing the drug recognized quickly which patients were on active therapy and which were on the placebo. She had a dramatic response to whichever agent she received, with resolution of pruritus and improvement in her weight, and her spleen size decreased from 21 centimeters to 13.5 centimeters. She maintained that response for a number of years until the summer of 2012. And then her course was complicated by varices, upper GI bleed, and recurrence of her symptomatic splenomegaly. Any thoughts now of what to offer this woman? She's now into her mid-70s. She had a nice response to ruxolitinib. So unfortunately, the panelists don't have much to add because there is not much in this situation. We did have other agents that were studying in the context of clinical protocols, but she had hyperbilirubinemia related to her disease, and she was not eligible for any of our protocols. So a couple of questions about JAK2 inhibitors in the treatment of myelofibrosis. And which of the following is not true? Number one, ruxolitinib is the only agent commercially available and approved for the treatment of myelofibrosis. Number two, patients without a JAK2 mutation do not respond to JAK2 inhibitors. Number three, approximately 40% of patients will obtain at least a 35% spleen reduction with ruxolitinib, and about half of patients will maintain a spleen volume reduction for about 144 weeks. Who are treated with ruxolitinib. And number five, anemia and thrombocytopenia occur with some frequency in patients treated with ruxolitinib. I should clarify that number one, ruxolitinib is the only available JAK2 inhibitor. Excellent. So exactly, patients, whether or not they have a JAK2 mutation, may respond to ruxolitinib or other JAK2 inhibitors. So a little bit of follow-up regarding the data with ruxolitinib. The study that, the large study, COMFORT-2, reported that at 3.5 years follow-up, there was a 42% reduction in the risk of death compared to the best available therapies of symptomatic control for patients. In addition, the probability of survival on the best available therapy arm was 54% versus 71% in the ruxolitinib arm. As occurred in my patient and has now been demonstrated with more data, ruxolitinib has been shown to both promote weight gain that occurred in a huge percentage of patients and improve total body cholesterol. We think that this is probably due to the reversal of the MF-related cachexia and catabolic pathways. So a couple of take-home points in myeloproliferative neoplasms. Allostem cell transplant decreases the risk of leukemic transformation, but it's not appropriate for the majority of patients, including ours who was studied. Prognostic scoring systems exist. Many agents are available for palliation. In ruxolitinib, we've talked about its indication, and there are many other inhibitors being studied. And just leave you with a flow algorithm of how patients with myeloproliferative or myelofibrosis in specific are evaluated and assessed for treatment. Thank you.
Right. Just out of curiosity, how many of you practice pediatrics or see pediatric patients in your treatment regimen, or rather in your practices? Wonderful. I appreciate that. So this patient is a 23-year-old man who presented with epistaxis, hyperbilirubinemia, pancytopenia, and frankly, the patient looked desperately ill. They looked quite diaphoretic and quite sick upon presentation. At that time, he had multiple erythematous skin lesions and hepatosplenomegaly. And one of the things that provoked was an evaluation for Epstein-Barr virus. The PCR initially demonstrated 8,200 copies per milliliter, rising to 272,000 copies. A biopsy of the skin lesions demonstrated the presence of an NK T-cell non-Hodgkin lymphoma with gamma chain gene rearrangements, and the bone marrow biopsy showed evidence of hemophagocytosis. Just to give you an idea of what that looked like, on the biopsy there were histiocytes and macrophages within the bone marrow and within additional tissues, basically gobbling up other cells. At this point, what would you be thinking about in a patient like this? Is this a type of patient that you've encountered before, or one for whom you might have a differential diagnosis in mind?
Some form of a macrophage activation syndrome would be something that one may be concerned about. HLH, of course, is one possibility.
Sure. Good. So going to our ARS questions, because this HLH syndrome, that's hemophagocytic lymphocytosis syndrome, has been raised, let's ask ourselves the following question. All the following are criteria used to diagnose hemophagocytic syndromes except for elevated liver enzymes, a fever greater than 38.5 degrees, elevated soluble CD25, which is interleukin-2 receptor, hypertriglyceridemia, elevated interferon level, or elevated ProTime PTT. You can go ahead and give us your responses. All right. We'll come back to this in just a little bit. So a little bit further with this patient. The patient was treated with foscarnet and rituximab directed at the Epstein-Barr virus and then received multi-agent chemotherapy. Initially they received CHOP. They got not very good disease control. They subsequently received a carboplatinum-based combination and achieved a remission, and subsequently underwent allogeneic stem cell transplant from an HLA-compatible sibling. And the patient remained well. The hyperbilirubinemia, the fevers, the constitutional symptoms abated, but 8 months post-transplant, we saw the same cataclysmic presentation with constitutional symptoms, hyperbilirubinemia, hemolysis, pancytopenia. And once again, the patient was found to have cytopenia and on the bone marrow, hemophagocytosis quite present. And despite our efforts, including multi-agent chemotherapy, the patient died from progressive non-Hodgkin lymphoma, but most certainly this underlying hemophagocytosis contributed to the patient's demise. So the next set of questions for you are, which of the following statements are true, or which statement is true, about hemophagocytic syndromes? One, they can either be inherited or occur sporadically in response to infections or other triggers. Two, they should be treated with allogeneic transplant, which for me would be ideal since I'm a transplanter. Three, there's a high mortality without treatment. Four, the most common infectious cause is CMV. Number 5 is 1 and 3. And number 6 is all of the above. Wonderful. Okay. Let's move forward to learn a little bit more about hemophagocytic syndromes. As Dr. Greenberg noted, an important thing in the differential diagnosis is hemophagocytic lymphocytosis. I would say that the differential diagnosis earlier can include things such as sepsis and other systemic infections. So it's important, even though we may move to this diagnosis, to remain mindful that more than one thing can be going on at the same time. These disorders are incredibly rare. They can occur either as a primary disorder or as secondary forms, which occur sporadically, related to a number of disorders, including infections, autoimmune disorders, and malignancies. With respect to the primary disorders, these are things that tend to happen in a pediatric patient population, and they are incredibly rare. The incidence of these disorders is 1.2 in a million. So literally, these are 1 in a million patients. These disorders, which are characterized by an autosomal recessive form of inheritance, are characterized as primary HLH syndromes. Familial syndromes are fivefold, and they involve gene abnormalities related either to syntaxin genes, to abnormalities in porphyrin formation, or in NK cell function. There are also inherited disorders where the same syndrome may be seen, like Chidiac-Higashi, Griscelli-2, Hermansky-Pudlik syndrome, and some of the other X-linked disorders. These are most frequently, the primary form of the disorder are most frequently diagnosed in the pediatric population in patients about 1 year of age. There may, however, be some individuals who are diagnosed with familial forms up to the 8th decade of life, so we shouldn't close our mind off, but the vast majority, 95%, will be diagnosed in the first 2 years of life. The majority of patients that we'll encounter, and we're talking about vanishingly few patients with this disorder, are typically those who suffer from a secondary form of the disorder. So in terms of infectious diseases, Epstein-Barr virus is the most common infectious cause. CMV is second most common. But parvovirus, HSV, varicella-zoster virus, measles, HHV8, H1N1 influenza, and that's maybe not so rare that we see this syndrome associated with H1N1, because I've seen a number of cases of patients who post-allogeneic transplant have come to the hospital with absolutely this cataclysmic presentation of not only the respiratory symptoms related to H1N1, but hyperbilirubinemia, profound pancytopenia. So again, these secondary things, particularly in immunocompromised patients, are the venue where we're more apt to see patients affected by this. You can also see it in avian flu, in SARS, and I've seen it historically in patients with HIV infection, particularly those with the HIV syndrome following acute infection, or those with very, very poorly controlled HIV prior to the era of HAART or CART therapy. In terms of immunological diseases, as Peter referred to, these can be called macrophage activation syndrome. And this includes immunological diseases where we know there are perturbations of the immune system, overactivity of T cells, cytokine abnormalities. So we'll see this in adult onset Still's disease, SLE, rheumatoid arthritis, mixed connective tissue disorder, sarcoidosis, systemic sclerosis, ankylosing spondylitis, Sjogren's syndrome, and even in dermatomyositis. Can also be seen in Kawasaki disease, and I think closer to those patients that I see can be seen in malignancies, particularly NK and T cell lymphomas and anaplastic large cell lymphomas, which I've seen about a dozen cases of HLH in patients with these two types of lymphomas. I've seen it once in a person with acute myelogenous leukemia. We can also see it in mediastinal germ cell tumors, which may be associated with severe thrombocytopenia and red cell destruction, and in some other solid tumors. So the signs and symptoms of these disorders are, again, this cataclysmic presentation of fever, jaundice, bleeding. Neurological symptoms are found in up to 75% of affected patients, including those with seizures, encephalopathy, ataxia. Patients may also have apathy and an abnormal affect. Patients may develop GI symptoms such as diarrhea. The skin rash can be seen both related to the disorder and is seen almost in 100% of patients, but it also can be seen in those with cutaneous malignancies. And finally, almost universally, hepatosplenomegaly is seen. In terms of the laboratory and biopsy findings, I think it's important just to think about what happens in these patients from a pathophysiological point of view. NKT cell function, or rather NK cell function, is quite abnormal. And in a reactive way, T cells begin elaborating enormous amounts of interferon gamma and TNF alpha. Subsequently, that triggers proliferation of macrophages, which begin elaborating IL-1 and IL-6. So it's a profound overactivation of the immune system, with the macrophages infiltrating the lymph nodes, the central nervous system, the liver and spleen, resulting in hyperbilirubinemia, hepatitis, hypertriglyceridemia, abnormalities of coagulation as hepatosynthetic dysfunction becomes destroyed, progressive renal failures, you have volume shifts, serum ferritin may go through the roof. Again, you're destroying hepatic architecture. And on bone marrow biopsies, lymph node biopsies, skin biopsies, and if you were to biopsy the CNS, you might see infiltration of histiocytes and macrophages that are actively gobbling up all the other cells in the body. So the diagnostic criteria include either the demonstration of a genetic lesion associated with HLH, and those are those 5 that I told you about, or the patient has 5 of the following symptoms. That includes fever, splenomegaly, cytopenia, either hypertriglyceridemia or hypofibrinogenemia, speaking towards liver dysfunction, hemophagocytosis demonstrated on a biopsy, an elevated ferritin, and an elevated IL-2 receptor. The one that's not on this list is interleukin or interferon levels, because those can be highly variable and are unreliable in terms of making diagnosis. So ultimately, this represents a profound state of immunological activation. For patients with the familial forms of these disorders, they are nearly 100% lethal, with a median survival of 2 to 6 months. The only curative path towards these patients is allogeneic stem cell transplant. When applied early, can result in up to 70% survival, but achieved at a very high 100-day post-transplant mortality. The majority of these patients die from infections because there's a difficulty because of the abnormalities within the immune system in these patients fighting off infections, particularly fungal infections. With respect to the more sporadic disorders, for the macrophage activation syndrome, it's immunosuppression with high-dose corticosteroids, cyclosporin, IV gamma globulin, and then all those anti-rheumatological antibodies that you see advertised on TV. All those can potentially have activity in the treatment of this disease. For those with EBV-related disease, rituximab and correct chemotherapy. And finally, for those with malignancy-associated HLH, disease-related chemotherapy. These are typically lymphomas, so we're talking about patients with lymphoma-specific combination therapy. And with this, the mortality is about 20%. So the take-home messages on this vanishingly rare disorder is that it represents a spectrum of both primary and secondary disorders. Those of you who practice pediatrics in the audience are more likely to see the primary disorder, whereas those of us who are adult doctors are more likely to see the secondary disorder. The diagnosis is based upon a constellation of profound symptoms, and I guess I would just ask you to look at these triggers. When you see a patient who looks disproportionately ill with hyperbilirubinemia, renal failure, fever, abnormalities in cognition, think about this syndrome, because it's going to demand, in addition to whatever you're treating primarily, it's going to demand that you quiet this immune milieu so that the patient can survive this. It's important to remember that delays in diagnosis relate to increases in mortality, and that for those patients with familial syndromes, allogeneic stem cell transplant may be the path towards a cure. Again, thank you very much for your attention.